All right, I see we still have people joining. While we still have a steady stream of people joining, I'm going to go ahead and get started with tonight's introduction, so that way we can give the platform to our speaker. So first and foremost, good evening, everyone. And seriously, thank you so much for joining us tonight. I am happy to introduce tonight's speaker, Nathan Vardi, who will be talking about his new book, I have it right here, For Blood and Money, Billionaires, Biotech, and the Quest for a Blockbuster Drug. Now, tonight's program is just one of our many, many author events that we have scheduled for our winter session. On January 18th, we welcome actor and activist Gina Davis, who will be in discussion about her new memoir, Dying of Politeness. Nature lovers are sure to enjoy Danielle Clode's fascinating research into the life and conservation of koalas on January 23rd. And botanist David Gibson will be joining us on Zoom to talk about the forensic relationship between plants and crime scene investigations on January 26th. I'm personally looking forward to that one. For a full list of our events, simply visit our website, hudsonlibrary.org. Now, copies of For Blood and Money are available for purchase, courtesy of Hudson's own independent bookshop, The Learned Owl. We'll add a link in the chat for easy purchase. We also encourage you to join tonight's conversation. If you have questions or comments for tonight's speaker, just use the Q&A box located at the bottom of the screen, and we'll try to get through as many questions as time permits towards the end of the program. Now, please let me introduce tonight's speaker. Nathan Vardi is a managing editor at MarketWatch and is also the former senior editor at Forbes. He has extensive knowledge and writing about big money investors, hedge funds, private equity firms, as well as the intersection of Wall Street and biopharma. Now, without further ado, please join me in welcoming Nathan. Thank you so much for joining us tonight.
It's a pleasure to be with you. Hello, Ohio, and people who are joining from elsewhere as well. My name is Nathan Vardi, and I am the author of the book For Blood and Money, Billionaires, Biotech, and the Quest for a Blockbuster Drug. How are amazing cancer drugs created today? This was the question I wanted to answer in my book. Imbruvica and Calquence represent one of the big breakthroughs in cancer treatment in the last 20 years. They have revolutionized the treatment of chronic lymphocytic leukemia, the most common form of adult leukemia. These are drugs that have made a huge difference for patients. While these drugs are the product of cutting-edge innovation, dedicated scientists, doctors, researchers, courageous patients who participate in clinical trials, administrators, executives, and investors, they are also the product of lucky breaks, rivalries, and conflict. For a while, these drugs were forgotten, literally just some white powder grunge languishing at the bottom of a test tube. So how did they ever get to patients? Here are some ideas from my book, For Blood and Money. The first idea I want to talk to you about today is that people who have experienced cancer through biotechnology have found a way to fight back. Imbruvica was developed by a small company called Pharmacyclics based in California. Pharmacyclics was co-founded by Jonathan Sessler and his cancer doctor, Richard Miller, who had treated Sessler for lymphoma when both were at Stanford. Miller treated him, and his chemotherapy was so bad that Sessler would reflexively throw up before his chemo appointments. But the treatment worked, and Sessler became a chemistry professor. His cancer left an indelible mark on him and motivated him to apply his knowledge of chemistry to cancer therapies. Sessler continued to see Miller at follow-up appointments, and during his visits, he would update Miller on his latest work. At one appointment, Sessler described his synthesizing of new molecules that could potentially make tumor cells more susceptible to radiation. He thought they could be designed to accumulate selectively in cancer cells. Miller was intrigued, and together they started Pharmacyclics to try it out. Sessler's approach did not work, Instead, Miller acquired a drug that pharmaceutics would later develop into Imbruvica, a novel cancer therapy. The company, Pharmacyclics, would end up being run by Bob Duggan, a man who had no experience in drug development before. He was a college dropout. He was motivated by the tragic death of his son at age 26 from cancer. So many people are impacted by cancer, either directly or indirectly, through loved ones, friends, work colleagues. And it's amazing to me how many of the key people I researched for this book had experienced cancer either directly or indirectly, one way or the other. The second insight I want to talk to you about today is about forgotten drugs. I've thought a lot about this over the last few years. Many drugs are trapped in the pipelines of pharmaceutical companies, waiting for someone to discover them like buried treasure. Even after years of innovation, good drugs languish in the bellies of big conglomerates, bureaucracies too burdened with their own processes and procedures to identify and develop these tiny gems. These drugs can be fished out from the big companies for pennies on, pennies on the dollar and developed to help patients. Imbruvica was created at a company called Celera Genomics. Celera shut down its development and didn't even bother to patent the drug. As CEO of Pharmacyclics, Richard Miller negotiated to buy it in a deal that centered around other drugs. In total, Pharmacyclics bought 3 drugs for $6.6 million. The way the chemists at Celera saw it, Imbruvica was essentially included in the deal for nothing. Calquence was created in the Netherlands at a company called Organon. Organon was sold to a New Jersey company called Schering Plough, which was then sold to another New Jersey company called Merck. Merck was not interested in Calquence. In fact, it wasn't interested in the Netherlands. It halted the drug's development and fired the scientists working on it, and it also shut down the whole operation in the Netherlands that it had acquired. The drug itself was bought by a startup called Acerta for an upfront cash payment of $1,000. The third insight I want to talk to you about today is about billionaires. It's my opinion that we need them to be involved in cancer research. In the last decade, there was a big shift when it comes to cancer drug development and the life sciences. A lot of the innovation has been coming out of small biotechnology companies, as opposed to big pharmaceutical companies, which preferred the less risky strategy of buying small companies that had already demonstrated success. These small companies are often controlled by their founders, some of whom are entrepreneurs. Others are successful hedge fund managers or venture capitalists. You can't start a biotechnology startup in your garage. It needs to be well-funded. So the people who start them tend to be people with serious means. In other words, the super wealthy. I talked to you a little bit before about Bob Duggan, who is a prominent character in my book. He was a successful businessman when he became CEO of Pharmacyclics. The company was headed for bankruptcy. Its stock in the stock market traded for as little as 57 cents. Duggan tried to sell a piece of Pharmacyclics' drug Imbruvica, but no person or company was interested in financing its development. So Duggan extended a personal loan of $6.4 million to keep Pharmacyclics going during those days. He also authorized the first clinical trial of Imbruvica in human beings. Calquence would have never been developed if it weren't for Wayne Rothbaum, a billionaire stock trader who operated under the radar in New York. After Merck shut down its development, Rothbaum personally funded the development of Calquence, risking a big chunk of his own net worth. And he got some of his billionaire buddies to shoulder the rest of the investment. The fourth insight I would like to talk to you about today is perseverance and unsung heroes. Raquel Izumi is a prominent character in my book. She was a senior director of clinical development at Pharmacyclics. She worked tirelessly there to design and enroll the key later stage clinical trials for Imbruvica. Her work was noticed. Bob Duggan, Pharmacyclics' CEO, called her into his office, gave her the biggest raise of her career, and called her a, quote, linchpin for the company. A month later, Duggan fired Izumi for reasons that he has never explained. I get into those reasons a little bit in my book. What I could tell you is that Izumi felt like she had done the best work of her career, maybe the best work she would ever do, and been fired for it. Not long afterwards, Izumi snuck into an important presentation of Imbruvica data at a big medical conference in Chicago. I recount this scene in my book. She was so proud of the drug she had worked on and so sad that it would be moving on without her. Izumi sat in her auditorium seat and cried. She persevered. Izumi co-founded Acerta, even though it might have made more sense for her to get a decent paying corporate job. She had 2 kids, she had a Silicon Valley mortgage, and for a while, Izumi was on unemployment insurance. But she was incredibly dedicated to finding treatments for patients, those who she knew needed help. At Acerta, Izumi wrote just about every clinical trial protocol for Calquence and helped get that cancer drug to patients. Izumi told me a story once that I put in the book about sitting at an airport bar during a layover and talking to the woman next to her who worked in clothing design. And the woman in clothing design turned to her at one point and said, you know, when things get really stressed, when we're really working hard, we always say, you know, calm down. It's not like you're curing cancer. But you're the one, the woman said, you are curing cancer. This kind of urgency, I found, was at the heart of everything Izumi did, her every success and failure. In researching this book, I found that there are so many people like Izumi who work at biotech companies and pharmaceutical firms. They really deserve our thanks and gratitude. Another hero I would like to talk to you about is John Bird. John Bird is an incredibly dedicated research scientist at The Ohio State University, not far from the Hudson Library. He is an unbelievable person. And I'll tell you a little bit about him. He worked his way from the brink of poverty in Arkansas through Army service to pay for medical school, to the James, the famous Ohio State Cancer Hospital in Columbus, where he is head of leukemia research. Dr. Bird first started working a lot with chronic lymphocytic leukemia patients when he was in the Army at Walter Reed Medical Center at the time in Washington, D.C. The CLL patients, chronic lymphocytic leukemia patients, were mostly treated at the time with very difficult chemotherapy. It really bothered him. We have to do better, he would say. At Ohio State, Dr. Bird was the lead investigator in some of the key trials of Imbruvica and Calquence. He had an incredible operation to push those trials forward because the James is such a large cancer hospital. He could enroll many patients in those trials. One of them was Brian Kaufman, who flew from Southern California to Ohio to participate in these clinical trials. Dr. Bird would send him back to California with capsules of Imbruvica. Kaufman would keep them in his pocket on the flights back to California, just in case there was an emergency that would force him off the plane. For Kaufman, these pills were the most prized possessions in his life. The fifth idea I was hoping to talk to you about today is luck. Because for all the tens of billions of dollars spent each year on cancer drug development, most cancer drug researchers are just stumbling around in the dark. Occasionally, a variety of factors, including luck, come together to produce a truly innovative winning treatment. It's a game of overwhelmingly negative odds. The vast majority of cancer drugs tested today in patients fail. Imbruvica was created at a company called Celera Genomics. It was created as a tool compound for rheumatoid arthritis. It was a covalent drug. So what does that mean? It means that the drug irreversibly stuck or bound to its protein target. Its target is BTK, Bruton's tyrosine kinase. At the time, pharmaceutical companies overwhelmingly shunned covalent compounds, and Imbruvica was really not meant to be a viable drug candidate. But Pharmacyclics acquired the drug, and its CEO, Richard Miller, decided to give it a try, not in rheumatoid arthritis, but in blood cancer, particularly lymphoma. When Miller wrote the plan for the first in-human trial of Imbruvica, he included in the study patients with chronic lymphocytic leukemia, or CLL. It was a bit unusual to include these patients in a lymphoma trial, but Miller had a good reason. In CLL, many of the malignant cancer cells are in the bloodstream, whereas with most lymphomas, the cancer cells are in the lymph nodes and other tissue. Miller wanted to be able to measure and observe how the drug stuck or bonded to the cancer cells. With CLL patients, he was able to do this with a simple blood sample, as opposed to cumbersome biopsies, which is really what would have been required in lymphoma patients. So Pharmacyclics went ahead and tested Imbruvica in humans with different lymphomas and CLL. It would end up making the biggest difference in CLL patients. I would also like to talk a little bit about patience. If you or anyone you know has had cancer, you know that everything changes once you get that diagnosis. And you then hope that there's a treatment out there that can help you or the person you care about. What's amazing is that without these courageous patients, there would be no cancer treatments. I dedicated my book to the patients who volunteer for clinical trials. I also write about them in my book. I want to tell you about a couple of them. Robert Azzopardi was 60 when he booked an appointment with Richard Furman, an oncologist who ran the Chronic Lymphocytic Leukemia Research Center at Weill Cornell Medicine in New York City. The appointment was really Azzopardi's last hope. After several rounds of chemotherapy, his doctor had run out of ways to keep his CLL at bay. Azzopardi had been told that he had 3 months to live, and he was advised to prepare for hospice care. As a last-ditch effort, he had been directed to Dr. Furman. Azzopardi's wife brought him in a wheelchair to one of Furman's examining rooms. The enlarged lymph nodes in Azzopardi's back pressed on his sciatic nerve, causing him to bend over from excruciating pain. He had not walked in months. The lymph nodes on both sides of his neck and under his arms had swollen up. At his appointment, as I describe in my book, Dr. Furman told Azzopardi he was a candidate for a clinical trial of a drug that at the time was codenamed PCI 32765. I don't know if it's going to help you, Furman told him, but it's worth a try. About 4 weeks into treatment, Azzopardi woke up in the morning and did not feel the familiar pain running down his leg. For a moment, he wondered if he had died. After a month of taking the drug, Azzopardi returned to Furman and sat waiting for him in Furman's examining room. When Furman walked into the room, Azzopardi got up, stood up straight, and this is what he said: "Hey, doc, look at me." What you have to understand is that before Imbruvica came along, there had been very little progress in CLL. Doctors had become really frustrated. I want to read you a LinkedIn message I received just this week after my book came out from a doctor who today has a big job at a major cancer center. This is what she wrote me. "I will never forget him. It was a young man in his early 30s. He had failed multiple rounds of chemo and had an abdomen that looked as if he was pregnant. I was a young attending, recently graduated, who had just taken a job at a CLL research and treatment program of a major hospital. I had been hand-selected to work with a prominent doctor. He supported me on this crazy idea to let me open therapeutic clinical trials at our center, even though he was not convinced they would ever work. Time after time, every single drug before Imbruvica had failed miserably. The patient had come to the initial visit in a wheelchair. He was being worked up to do a life-saving allogeneic stem cell transplant, but because he had so much tumor burden, there was no way he could proceed. He needed something, anything, that could, quote, debulk him. So his physician referred him to me. I asked him what he wanted from the participation in the trial. He said he only wanted to be able to walk again without help and to go back to work at McDonald's so that he could feel alive again. Even as I write this, I get tears in my eyes. I needed the help of 2 men to put him on the bed to do a physical exam. He barely had any skin folds. His skin was so tight from overstretching from the bulky adenopathy. We planned to start him on a clinical trial on a Monday. I gave him my personal cell phone to call me with any new issues. After all, this was my first clinical trial patient, and I was a brand new hematology attending. I was scared. By protocol, I was supposed to see him again a week or so later, but I couldn't wait. Since I had not heard from him, I called on a Friday night before the weekend and asked how he was doing. This was his answer. Hi, doctor. All is well. I just finished vacuuming my whole apartment. How are you? The next time he came to the office, he came walking on his own. He started playing with his skin, showing me how much tumor was gone and how he could now pinch his skin. He couldn't wait to get back to work. I remember coming home and telling my husband, I have just witnessed a miracle. It reminds me of the Lazarus story from the Bible. I can't believe my eyes. It would take us many years and many additional clinical trials to prove that these drugs were more powerful and safer than chemotherapy. And now, a decade later, people can expect to live normal lives. Many of these patients that participated in these early trials are still alive because of the drug. I still keep in touch with some of them. Very few times are we privileged to witness true miracles during our careers. It's so important to remind ourselves of the real life and death, what's really at stake when we talk about things like cancer drug development. The 7th insight I was hoping to talk to you about today is just to give you a sense of the drug development process, because to a large degree, that's what my book is about. You would think that creating a great drug would be the hardest part of drug development, but what happens after the drug is created is equally important. If it's not handled correctly, the drug will never get to patients. The drugs I write about in this book are small molecule drugs. They target and infiltrate malignant cells, and they block an enzyme that helps cancer cells multiply and stay alive. Small molecule drugs have been such an important innovation in cancer treatment, especially compared to chemotherapy, which is kind of like a carpet bomb that indiscriminately kills both good cells and bad cells. To be approved by the Food and Drug Administration, the FDA, which is the US regulator, a drug needs to travel through a regulatory thicket of preclinical tests in labs and animals. Then clinical studies have to be conducted in human beings. Phase 1 trials that test the drug in a small number of patients, maybe as few as 20. Phase 2 trials that gauge the drug's safety and effectiveness in a larger group of patients. And big phase 3 trials that often compare the drug against other treatments to gain regulatory approval. For a single cancer drug, the cost of all these trials and development can exceed $1 billion. This is where the money part of my book comes in. For Blood and Money is the title. Often, drugs only get one chance to travel through this regulatory maze. The regulatory strategies of biotechnology companies then truly become elaborate games of chess, weighing the needs of regulators and often countering the moves of rivals. I would also like to talk to you a little bit today about overcoming setbacks. Wayne Rothbaum is a major character in my book. For years, he was a stock trader who operated in New York. He traded stocks of biotechnology companies, and he knew the science of drug development back and forth. He was very early in seeing the potential of Imbruvica. He understood its mechanisms of action very well and thought it was promising. So he bought a lot of stock in the company that was developing Imbruvica Pharmacyclics. He bought shares of Pharmacyclics when they were trading for $1, between $1 and $2. But then he got spooked by some clinical data, and he sold most of his Pharmacyclic shares for about $6. So that was a good return, buying at $1 and $2 and selling at $6. And then Rothbaum watched from the sidelines as Imbruvica's stocks soared to $10. Then it rose to $50. Then it went to $100. It would ultimately reach $261. Selling Pharmacyclics stock early was the biggest mistake in Rothbaum's career. It really bothered him. So he channeled all his energy into backing and building other drug development companies like Acerta, a rival cancer drug. Acerta's drug Calquence, which is a rival cancer drug to Pharmacyclics. Looking back, at least from my perspective, the trading setback was the best thing that could have happened to Rothbaum and the cancer patients who today take Calquence. I also want to talk to you about the golden age of biotechnology. My book, For Blood and Money, is about the golden age of biotechnology investing. I wanted to tell a story that epitomized this era. In the 2010s, there were new gene therapies that were developed. They replaced defective genes with healthy ones to treat diseases. Immunotherapies that were game changers for cancer patients were developed. And innovative medicines for rare diseases and HIV also came along. About 400 new drugs were approved by the FDA between 2010 and 2019. And a big chunk of those drugs were oncology medicines. Biotechnology companies played a very big role in developing many of these new treatments. And you could see their successes in the stock market, where biotechnology stocks soared. In fact, the index that's most widely used to invest in biotech companies returned 351% in the decade ending December 31st, 2019. So that beat the NASDAQ composite index of high technology companies like Amazon and Microsoft during the same period, which returned 343%. And biotech shares absolutely beat the pants off the wider, broad stock market as measured by the Standard & Poor's 500 index. Pharmacyclics and Acerta, the two biotechnology companies that I write about in my book, arguably represented the peak of the biotech boom. After researching my book, I increasingly think that the golden age of biotechnology investing might be coming to an end. It's not just that the biotech stocks have performed very poorly, which they have over the last 16 months. That's largely occurred, in my opinion, because the Federal Reserve, the US central bank, has been tightening monetary policy in order to fight inflation. And that has sucked out speculative capital from the biggest risk-taking segments of the market, like biotech. There are also political, regulatory, structural obstacles that the biotech sector now must overcome. So let me get a little technical here. Congress has made it a lot harder and more expensive, as has the FDA, for drugs to be approved through the accelerated approval program. This is a program that green lights medicines for the treatments of diseases fast based on smaller studies of patients, often, only single arm studies where a drug isn't tested against another drug or a placebo. Last year's Inflation Reduction Act will soon allow the government to negotiate prices on the most expensive medicines covered by Medicare. That will likely cause drug companies to release generic versions of their treatments early. As a result, the value of patent-protected branded drugs will diminish. And the legislation also will complicate efforts by biotech companies to get their drugs quicker to market. The FDA also has something called Project Optimus, which is changing the way drug companies must look for dose optimization, figure out the right dose of their drugs for cancer patients. And that's going to make things more complicated, I believe, for biotechnology companies. In the past, biotechnology companies would try to, in their early trials, quickly find the maximum tolerated dose that patients could take. The most dose of a drug that a patient could receive while not having side effects. But now the FDA wants to change that. It wants biotech companies to look for where there's efficacy in a drug at lower doses. And I think that's going to be difficult for a lot of companies to do. Regulators are also increasing the number of clinical holds that they issue on biotech companies. There was a Wall Street Journal story about that this week. And then there's structural headwinds that biotech companies face, just like every other company in the economy. They're facing inflationary pressures. That means it's going to cost more for biotech companies to run their clinical trials. So I think, it's tempting to look at the biotechnology sector today, at least in the stock market, and think that there's another pharmaceutics in there. I told you before that pharmaceutics was trading at one point for 57 cents, and it ended up going all the way up to $261. And, I think there probably is one, but I do think that biotechnology investing is going to be harder. I do think good medicines will still be funded, but on the surface, it's unclear to me what all this will do as far as innovation for patients. There have just been so many changes to the regulatory, political, and economic environment, and that's why I think that way. The Economist reviewed my book this week. It was a very generous review. And I thought the writer asked a really legitimate question at the end of his review of my book. This is what The Economist wrote, quote, "This high-risk method of finding a new cancer treatment certainly works. Yet the reader is left with a nagging question. Is this testosterone-fueled, profit-driven process really the best way to develop life-saving drugs?" It's a really good question. I would say so far, it's the most tried and true process that we know of. But I would be interested to hear if anyone listening today has different ideas. Thank you for listening to my presentation. It's been a pleasure talking to you about my book, some of the issues and characters it hit on, and I'd be happy to answer any questions that anyone has.
Thank you so much, Nathan. Absolutely. So if you have any questions, please feel free to use the Q&A box down below, and we'll start asking questions. In the meantime, I just have a couple of questions for you myself. There are so many startup biopharm companies, right? What was it specifically about this story, out of the slew of other stories out there, that made you want to document and write about this case?
I really wanted to tell a story that epitomized the biotechnology boom that took place in the previous decade. And I felt like this story did that more than any other. I think that the companies themselves, as far as the financial returns associated with them, really do represent the peak of the boom. And I also think the story behind these drugs, some of the themes that I talked about today, like forgotten drugs, really was captured in this story. When I would talk to people in biotech and in pharma and tell them I was writing this book, I would get two reactions. People who didn't know this story would say, why are you writing that story? I don't know, why are you picking that one? And then people who knew the story would always tell me, I always knew someone was going to write a book about this one day because it's such a wild and crazy story. And, it's a story where the outcome is not in debate. The outcome for patients has been phenomenal. And so it's kind of interesting to reverse engineer how that took place.
Do you know offhand an estimate of like how many patients have been prescribed either of these medications? Like how many people this has actually helped improve their lives?
Hundreds of thousands.
Impressive. And then also,
it will be millions. I mean, because it's going to.
Right. I just saw the one was approved for Japan recently. I think it was just within the last 2 weeks. So it's getting even greater use around the world. So that's
right.
fantastic.
Calquence was approved for Japan recently. And, these drugs are used in a lot of different indications. But I talked a lot about CLL in my talk and also write a lot about it in my book because it's a very, very widespread cancer. It's really the largest blood cancer that exists. So it's not like a rare disease. It affects a lot of people. Right.
I'm curious about the process of writing this book. So obviously, I believe you wrote this during the pandemic, if I'm correct. But there's some really interesting characters in here, including someone who like never wants to be photographed or interviewed, kind of lives off the grid in some ways. What was it like getting all of these people on board and getting their stories for this book?
When you write something like this, you're not going to bat 1,000. But most of the people who were involved in this story were very interested in talking to me and telling me about it because it's so rare to be involved in something like this. And people can work in cancer drug development their whole lives and never be close to anything like this. I talked to you a little bit about Raquel Izumi, who's one of my favorite characters in this book, and I think she's just a wonderful person. And she originally got involved because she had seen very, very early phase 1 data for Imbruvica, and she just wanted to be close to something like that because it was so exciting to her to be just even near it. And so I think for a lot of people, it's a really exciting thing to be around.
I know we do have a question in the audience, and it was something that kind of came up a little bit in your book too, where I believe you even mentioned that it was said crassly, but honestly, that people that are investing like to look at the price point of what a medication is going to be. And even what was deemed a subscription model, meaning you were never going to be able to stop it if it didn't have just a finite period of time using it. Do you feel as like a journalist writing this book, because you're kind of having to straddle and understand all sides, the battle on affordability and prescription medications, as some drugs are just almost impossible to afford? And Imbruvica, if I remember, it was expensive per month.
It is now too. These are incredibly expensive cancer medications that cost in excess of $170,000 a year. And you're right. You have, a patient has to continue taking them. So it's a constant thing. I try to show both sides of this issue in my book. I certainly write about patients who found it difficult to afford the drug. The patients who would struggle the most were those that found themselves in a kind of donut hole where they would have to pay $8,000 or $9,000 a year out of pocket to meet their deductible or their obligation under a plan or under Medicare. And that would specifically hit people who are middle class, so that they don't fall in an income exemption, but they also aren't wealthy. And that's a really tricky thing. And I think that there's a completely legitimate public debate in this country about drug prices. And, we're going to have some changes about how drugs are priced, starting with the Inflation Reduction Act last year. At the same time, I wanted to tell a story about how drugs, at least during the biotech boom, were developed, and the considerations that people who were developing these drugs and investing in these drugs were making. So I try to do that without judgment, so that people could just see what it is. Again, the outcome here is a very good one, in my opinion. Like, these drugs are incredible drugs that have really made a difference for cancer patients. And I don't know, when we start tinkering around on the pricing structure, what that will do to innovation. And I really mean that. I really don't know. I'm not saying it's going to, create less innovation or more, or won't impact innovation. It's just, this is also complex. But my book tells the story of an era and how that era functioned, and we'll see what happens in the years ahead.
Right. And I think, speaking, I guess maybe for myself, it's a bit of a double-edged sword, right? Because you do have to, as you said, one of your first points is you do have to have billionaires involved as the funders, the hedge funds, the venture capitalists, to be able to back these small companies, because it's so expensive in order to get that. And I'm guessing, based on the amount of money it's requiring to do all these FDA trials and everything, eventually you are, as you said, you're going to sink a ton of money into these drugs, and they're going to have to recoup their costs at some point. But it's definitely a cultural debate. And we've had some comments regarding that. And I can completely understand. One thing I wanted
I do too. I really want to be clear. I completely understand. That's why I wanted to bring up that comment from the Economist review. Is there another way to do this? I mean, it's a great question. It's a great question.
Absolutely. And I do think, as someone who has read your book, I have read it, and I think you do bring up both sides. There are moments where you are reading this and you kind of feel a little uncomfortable knowing that the head of this company does not have a medical background, but is urging doctors to change protocols, change testing, very aggressive, because they're thinking about the bottom dollar, the money that they're putting into it, right? And I'm sure some of the scenarios writing the book that I'm talking about, and it does get a little uncomfortable thinking about how close they are to some, especially like trial data of patients and what they are going through and what their lab results are looking like. So anyway, we will go ahead and segue a little bit from that. Mary wants to know, this is a good question. How long does a drug have to be on the market to create a generic? And do you foresee, I probably not, but do you foresee any of these cancer drugs forming generics?
I didn't understand the last part of the question.
Do you think there'll be ever a generic version of these two drugs you talk about in your book?
That's a really excellent question. The patent life is a 2-decade thing. In the case of Imbruvica, which today is owned half by J&J and half by a large pharmaceutical company in Chicago called AbbVie, and AbbVie has been very aggressive in filing patent extensions and winning patent extensions for the drug. So it is a totally legitimate question to ask, well, when are these things going to go generic? The answer to that is I'm sure eventually they will, but there does seem to be a real effort by at least AbbVie to extend the patent life of Imbruvica.
Makes sense. you mentioned that the investing age with like the golden of biotech is kind of fading due to government regulations, the Federal Reserve tightening, interest in the increasing the interest rate, et cetera. Because the model has been, Johnson & Johnson, Merck, whomever, they are seeking out these smaller companies and kind of partnering with them or working or just acquiring it once they actually have something. Do you feel that that model will shift a little bit? Do you think maybe these larger companies will go back to testing themselves, that maybe it would actually become more economically feasible with these changes? I know obviously you're not a fortune teller. I'd just like to know your thoughts on that a little bit.
Yeah, well, so far, it's my opinion. It's an opinion that the biotechnology sector is gonna have a tough sledding, over the next decade. Actually, that's already happened. The pharmaceutical companies, the big ones, have grown tired of watching the biotechnology companies kind of take the lead in innovation. And they have decided they want to invest in their own pipelines. And so an example of that that I always give is Pfizer, which is an enormous US pharmaceutical company. In the 2010s, well, if you look at Pfizer, what were they doing? They were doing big mergers or trying to do big mergers. They were very focused on tax arbitrages, international tax arbitrages. And then if you look at them now, like what have they done? They've divested their veterinary business. They've divested their consumer products business. They've divested their generic drug business, and they're very focused on developing new products and vaccines. And so they've absolutely, we've seen a shift that some of the pharmaceutical companies want to be more involved in innovation. And you see it. You talk to biotech people and they will tell you that when they talk to the pharmaceutical company business development people, who are the people who, if there was going to be a deal, would be the ones who would pursue it. And, the first thing when they meet with the biotech companies, they always say, well, I have to check my internal pipeline before I decide what to do here. So let me get back to you. And that really represents the shift that's been taking place.
They kind of wrote this a little short, so I'm not sure, but I think I know what they're talking about. Are there any nations or even the United States that are subsidizing the research and development of drugs?
100%. 100%. Like, first of all, the United States government spends a tremendous and meaningful amount of money on research, particularly early research, through different institutions like the National Cancer Institute, and with medical centers and with academic centers. And that has been crucial to advancement in medicines and our understanding of a lot of things. But I'll tell you that in the case of the two drugs that I wrote about, that's not the case. The government had nothing to do with the development of these drugs. The National Cancer Institute started to really tinker with the pathway, not even the mechanism, but the kind of pathways, the B cell receptor pathway, that these drugs are involved in their laboratory after pharmaceutics was already testing their drugs in human beings. So they were far along before the government any government funded research had anything to do with it. But that's in this case, broadly, the US government is, one of the chief avenues for early research that we have.
Absolutely, but I'm sure it's also a really competitive arena to be able to get their attention and to be able to acquire funding, let alone enough funding, because they probably can only maybe partially fund part of the research or something like that as well.
But the companies benefit tremendously because they can watch and build off of it. So it's part of what's made the system work.
Right. And I know that you have covered a lot of this through your writing, both for Forbes as well as writing for MarketWatch. But for anybody watching tonight, how else can they keep track of you or what you're writing about or anything with biopharm?
I do. I am an editor, so I don't write as much as I used to. There's tremendous journalism going on all the time on biotech, pharma, cancer drug research. I think the Wall Street Journal is a great resource. A lot of the big newspapers like the New York Times. There are also like specialty publications like Stat News that I think are really terrific. The traditional, science and all those sorts of journals. So I look at the media as a mosaic. You got to like piece your understanding together by reading all sorts of different things.
Absolutely, makes sense. Well, I just want to say thank you so much, Nathan. I encourage everyone who attended tonight, pick up a copy of For Blood and Money. You do not need a medical background nor a business background to understand this book. It's written very, very accessible. So even if you're the novice in understanding technical terms and jargon, you completely understand it. And the testing sections of this book are absolutely thrilling, the way they were written. So thank you so much for everyone for joining us. And thank you, Nathan, for coming and talking about your book. It was greatly appreciated.
Thank you very much. Thanks for having me.
All right, everyone. Have a great evening. Thank you so much. Bye-bye.